Severe submucosal fibrosis remains one of the most challenging situations during peroral endoscopic myotomy and may result in procedural failure. Endoscopic rescue strategies include the creation of a new submucosal tunnel or intramuscular tunneling. More recently, a case of mediastinal tunneling has been described. We present a rescue transoral mediastinal myotomy performed as follows. A mucosal incision is made and the muscular layer is transected at the area of fibrosis. The endoscope is advanced into the posterior mediastinum and a short tunnel is created along the axis of the esophagus. We then proceed with myotomy of the longitudinal muscle layer, followed by the circular muscle layer up to the level of the cardia. The adequacy of the myotomy is evaluated by both direct intraluminal inspection of the cardia and impedance planimetry. A 40-year-old woman presented with recurrent dysphagia and regurgitation 10 years after laparoscopic Heller myotomy. Endoscopy showed a tight stricture of the cardia. POEM was planned using a posterior approach. Following mucosal incision, extensive fibrosis was encountered, and repeated attempts to separate the mucosa from the muscle layer were unsuccessful. An anterior tunnel was not attempted because of the previous surgical myotomy, while intramuscular dissection was deemed unfeasible. The endoscope was therefore advanced into the posterior mediastinum and a 5 cm long tunnel was created parallel to the posterior esophageal wall. At this stage, the anatomical landmarks for the myotomy are illustrated: the longitudinal muscle layer, the intermuscular space, the circular muscle layer, and the submucosal space between the mucosa and the muscle layers. First, intermuscular injection was performed between the two muscle layers to facilitate controlled dissection, and the longitudinal muscle layer was divided using spray coagulation mode. Then, a submucosal cushion was created to protect the mucosa from thermal injury, and the circular muscle layer was dissected. These steps were repeated while advancing towards the cardia. During the procedure, the adequacy of the myotomy was evaluated by direct inspection of the cardia as well as by impedance planimetry, with initial values confirming the presence of a firm stricture. Progressively, the depth of myotomy was extended up to 5 cm. Adequacy of myotomy was confirmed by both direct inspection and impedance planimetry, demonstrating a distensibility index of 3.6. The mucosal entry was closed with endoscopic clips. The patient experienced mild post-procedural thoracic pain. The following day, a CT esophagram was performed and demonstrated no leak into the mediastinum, with rapid passage of oral contrast into the jejunum. Additional findings without clinical significance included a mild pneumothorax, pneumomediastinum, a small unilateral pleural effusion, and mild capnoperitoneum. The patient was discharged the day after the procedure and received oral antibiotics for 6 additional days. At the 2-month follow-up, the ECAR score improved from 11 to 3. The entry point in the mediastinum is dictated by the location of the fibrotic segment. At this level, the muscular layer is carefully divided, allowing the endoscope to advance along the external surface of the esophagus. Assessing the length of the myotomy is challenging because anatomic landmarks are absent within the mediastinal tunnel. The following strategies may help: intermittent impedance planimetry to measure cardia distensibility during the procedure, direct endoscopic assessment of cardia opening after completion of the myotomy, comparison of the depth of advancement within the mediastinal tunnel with the corresponding intraluminal distance from the incisors to the cardia. In conclusion, this case shows that transoral mediastinal myotomy is a feasible rescue option when severe fibrosis prevents submucosal tunneling during POEM. Impedance planimetry helps confirm an adequate myotomy. To reduce thoracic CO2 and fluid accumulation, CO2 insufflation and saline immersion should be minimized.